Hello everyone, welcome to this webinar. My name is Zoe Gabri and I'm Chief Product Officer in Advantis Medical Imaging. So thank you all for joining us in today's session. So the present webinar is mainly focused on decision making in tumor surgery. More specifically, we will review the effect of computational tractography and connectomics research on the surgeon's decision-making process on a theoretical level, but also through the review of two real cases. To do so, we have with us Dr. Sigar Bahadir, Chief Resident Neurosurgeon in Hazrat University Medical School. Any questions that may arise can be sent to us during or after the presentation in the Q&A section that you can find at the bottom bar of your screen, and at the end we will try to address as many of them as we can. So Dr. Bahadir, whenever you're ready, the floor is yours.
Thank you very much, Zoe. Good evening, everyone. Today I will discuss the concepts of brain metaplasticity and how it affects our surgical decision making and how we utilize the concept in post-surgical rehabilitation. My name is Shiar Bahadir. I am the Chief Resident Neurosurgeon of Hacettepe University Medical School, Department of Neurosurgery, one of the chief residents from Ankara, Turkey. So let's start. So I will start with the presentation plan. My plan is to first talk about localizationist and associationist approaches to brain function and how they evolved, how they came to be. And then I will move on to talk about briefly about recent developments in brain imaging, DTI and fMRI. Then I will move on to this new topic in brain research called connectomics and its implications in understanding the brain function. We will then talk about the concepts of meta-system, meta-network, and metaplasticity. Then I will present two cases. The first one is going to be a patient with aphasia in frontal aslan tract damage. And the second is going to be a clinical picture that is called Gerstmann syndrome, which goes with acalculia, agraphia, and finger agnosia, which means inability to do calculations, simple calculations, inability to write, and inability to name their fingers due to a tract called superior longitudinal fascicle damage. And then we'll have our concluding remarks and questions and answers, if there are any. So let's first talk about what is the localizationist approach and what is the associationist approach to brain function. These two schools of thought are about the physical brain and its relationship with our behavior and cognition and cognitive abilities. So the first school of thought kind of proposes that the brain has a stationary map, and the associationist school is more on the side of they believe that the map is always changing. The localizationists think the brain is a mosaic of feeling, thoughts, and emotions, and there are certain places that store it. Actually, this is the historical perspective. Actually, the modern thought is a bit different than this, and the associationist school believes that we create behavior by integrating parallel and interconnected networks spatio-temporally in the brain. So briefly, let's talk about the localization approach. For a long time, brain processes were thought to be located in certain places at the brain. So and they had this more rigid paradigmatic approach to where some certain traits are located. Localizationists would propose that there would be some anatomical and functional organizations in highly specialized, eloquent, so-called eloquent regions, such as the Broca's area or Wernicke's area. And any insult to those places would necessarily lead to persistent neurological impairments, as opposed to the non-eloquent areas where it would be safe to perform any kind of surgery. So the historical account actually starts with like 200 years ago with a doctor called Pierre Florence, who actually proposed that half of the brain, the halves of the brain do different functions than each other. But then we can actually trace it back to Joseph Gall, this idea to Joseph Gall, who is the founder of phrenology, if anyone knows the word. So he proposed that characters, emotions, and thoughts are located in specific areas. That's the main idea that this approach was based on. But then Broca defined the Broca's area, which is the area of speech articulation. And he reported that a neurological damage of the third frontal circumvolution causes a reduced capacity to speech articulation, and that was coined that for decades we believed that language articulation is located at Broca's area, and if it is damaged, then it is damaged. There's no going back. And around a decade later than Broca, Wernicke, who is actually the founder of associationist school, again found another area which he proposed that was used in word comprehension. So the mosaic idea of eloquent and non-eloquent brain regions arised with these kind of experiments and findings, and this was the main understanding of brain for a very long time. But the associationist approach was contested after, through years, physicians had a chance to see what happens to their patients after lesions, after tumor surgeries, after strokes. And what physicians have observed was that there were actually post-lesional functional improvements over decades. And they called into question this rigid view of understanding the brain, and the concept of neuroplasticity was suggested. That is a continuous process that enables neurosynaptic maps to adapt to optimize cerebral function. So again, as we told, Wernicke is the founder. We can say that Carl Wernicke is the founder of this associative school. And he considered associative connections as central building blocks for high order cerebral functions. In an area where neuroanatomical work was flourishing, Wernicke thought that brain was formed by a myriad of areas which held the motor images and sensory images of different modalities of thoughts and emotions and the like. And what created the behavior or the self or whatever you call it was an interaction between those. Of course, the localizationist approach was, and his the main thing that he based his idea on was the aphasia, was the kind of aphasia that we now know as conduction aphasia, which is caused by the loss of link between Wernicke's area and Broca's area, and it is mainly characterized by the inability of patients' inability to repeat words that we tell them. So this school remained dormant after Wernicke. Much later, in 1960s, revived again by Norman Geschwind, who had proposed some primordial accounts of networks working together and made some simple charts, simple for now, charts that described how they work together. So let's move on to recent developments of brain imaging and how they affected both of these schools and our thinking. So what we can do now that is different from before is that we can do lesion mapping studies in vivo. This was historically only possible post-mortem. After the patient dies, you make a cadaver study and then you find out what happened to them. Or in very special conditions, like case of Phineas Gage, people that are familiar with neurosurgery probably know his name. He had this frontal damage and was an object of interest for a long time. So we have techniques called diffusion tensor imaging and functional MRI, and intraoperative cortical mapping, and also other computerized methods for mass studies. Like we can work on hundreds, even thousands of patients at once, and we can get more global brains or global features of networks this way. This is what we have that back then Wernicke or Broca didn't, or Joseph Gall didn't. So let's talk about diffusion tensor imaging very briefly. What this does, it's a kind of MRI that captures the movement of water molecules. And what does it mean? So the water moves along the axes of the axons. It is confined in an environment that is created by axons, and it moves in certain directions, not in others, as they cannot penetrate axons. So we can predict that wherever way the water molecule moves, that has to be how an axon courses. So we reconstruct brain tracts from this movement data obtained from water molecules, and we can create a whole brain tractography, a whole map, as you can see here, of the brain is very possible, and it is very easy to make now, which was only possible with cadaver studies and white matter dissection before. What it does, it gives us a static map of brain. So your brain is like this, and at this historical time when this MRI study was done, this was the shape of your brain, and that's it for a second. On the other hand, functional MRI, although it has less spatial resolution than DTI, it gives us some idea about how different areas of brain work together, and it captures the temporal variations, and it also gives us an idea about this different neuronal assemblies that work together to create our perception, our cognition, and conation. Functional MRI mainly captures the increased blood flow in functioning area of the brain, and it's showing it to us. So the links between brain areas, the links that are shown between brain areas in DTI and functional MRI are mainly the same. So if we see a high correlation I'm sorry, if we see a higher order connection in DTI, we usually see it in fMRI, but fMRI also shows us that some other connections that we wouldn't expect seeing when we look at the DTI only. So there's two types of MRI. One of them is the task-based fMRI, shows which part of the brain are working together while performing certain tasks. And resting state fMRI shows which areas of brain work together when the person is not doing anything special. But even then, it shows that when we just lay there doing nothing, the brain is ever working, always on, and it's always doing something. So although, as I said, although fMRI functional connections usually share similarities with structural or DTI connections, there are still communications between different weakly connected areas that can be seen in fMRI. So I want to talk about computational connectomics, or we have structural and functional connectomics, but I will mainly talk about structural connectomics now. It's a computational method for analyzing brain network architecture with methods from graph theory, which is used to analyze many kinds of different networks until now, like mainly social networks, but it is used to understand transportation networks and any other kind of chaotic, non-reducible network structures. It is a useful method to analyze these kind of structures. So what do we do? How do we perform a connectomic study? We get a DTI image, and then we perform tractography. We divide the cortex into some regions. This image is from one of our studies, and it's showing the steps that we took for our study. And then we divide the cortex into different areas, and then we create a connectivity matrix, which is a mathematical representation of which area in the cortex is connected to where, through how many connections, and what is the strength of those connections. And this is also a slide from our presentation. We have shown that there are some different regions that with different strengths. With this red one, this blue one is being the strongest. The precuneus is the most central, seemingly most central part of the brain. It was actually shown before, but we have shown it with a different method. So all these advances in computational radiology of imaging of human brain have led us to understand the neural mechanisms much better. And you can see here a network created from a real brain. And from such studies, we have explored the idea of neural subsystems. This is not new, actually. This is coming from neuroscience, but we as surgeons, neurosurgeons, are not really too acclimated to these kind of topics. So some of those neural subsystems are sensory motor cognition, visual and spatial cognition, language and semantics, working memory, episodic memory, mentalizing, and social cognition. I am not reducing the whole brain into these categories. There are some other ones, but these were the main ones that we might that you might want to explore later. So we have to understand that the brain has these kind of subsystems, but there is a way for these subsystems to work. We have to understand this concept of segregation and integration and what they actually mean. It's a very important concept, in my opinion, to understand our approach that we take with our patients. So a segregated activation of these subsystems mean that they only involve one of these systems. And it is usually a simple task that we want the patient to perform. For example, in an fMRI machine, in an MRI machine, the patient performs simple finger tapping, and we are looking functional activations in the brain area and to understand which part of the brain is relevant to that movement. And what we see in simple tasks, such as I said, finger tapping, only one of these subsystems are actually activated. But in complex tasks, they require multiple subsystems to work together. So what we call, this is called integration of different subsystems. You can see here, this is a good example. They are actually functionally segregated little networks under the whole network, and integration is what makes them work together. As I said, simple for segregated and complex for integrated, but there are some other things behind this too, which we can, physiologically and psychologically can understand and categorize. So effortful, goal-directed behavior, and that aspect of cognition is usually relevant to integration, integrative functional integration. And effortless automatic behavior is usually related with segregated activation of certain brain areas, certain brain networks, let's say. And conscious processing, what we think, we know that we think, is a result of integration, while unconscious processing is probably a result of the segregation. After understanding these concepts, we can talk about the meta system and metaplasticity. Meta system, these are actually, again, these are not new concepts. They have been in neuroscience for a long time, but in neurosurgical practice, these concepts are just started to gain some strength. So at a meta system, we can define it as transitory, task-induced changes in integration between brain regions encompassing specialized functional systems. This cross-system interaction allows the resulting meta-systems to support functions that transcend those of specialized network. And metaplasticity from this is brain's ability to context-dependent meta-system reconfiguration. So brain can reconfigure itself depending on the context, even though it is insulted in some way to work and solve that same problem that it has dealt with before. And now I would like to, as I believe that we have understand the main concept. It would be a very long talk if we wanted to, thoroughly explore them. But we can, I think, move to our case presentations. So our first case is a case of aphasia due to frontal ascendant tract damage. I want to show the frontal ascendant tract and where it is located here. It actually synapses with arcuate fascicle, and it governs the motor aspects of language, some of the motor aspects of language production mainly. But what we have seen in our patient was also, other than motor functions, he had problems in understanding language too, although it was subtler than the aphasia. So the patient was a 28-year-old male with no medical history, and his chief complaint was a tonic-clonic seizure. Happened first time in their life. The patient then applied to an emergency unit where a CT scan was obtained, and the patient was referred to a neurosurgeon. The patient applied to another neurosurgery department, and the MRI obtained there showed a cortico-subcortical mass centralized on left cingulate gyrus with extensions to frontal lobe and corpus callosum. The mainly non-enhancing character and infiltration pattern suggested a low-grade astrocytoma. Let me show you the video that Ms. Zorigiauri have prepared for us. You can see the mass here as we have described. I will move a little bit more, and you can see now we are going to perform tractography to show the frontal ascendant tract and its relation to tumor. As you can see here, the frontal ascendant tract is very, if you have seen what I have shown you before, it is very thin, and the program is not really able to show it entirely. This might not mean that the tumor completely destructed the frontal ascendant tract, but rather, as I told you, the ETI uses water molecules, water movement, and what we are seeing here is a distortion of water movement due to the mass effect of the tumor and vasogenic edema. And this edema disturbs the water movement, so we cannot reconstruct the tracts as well. But nevertheless, this also shows that there is probably a physiological burden on that certain tract too. So you can see here the other side of frontal ascendant tract, which is very healthy, looks very healthy and normal compared to this side. And from here, I would like to also move to show you another important tract with this patient. Here, this is the patient's corticospinal tract, and we are seeing here, what we are seeing here is that corticospinal tract is pushed backwards significantly, while the frontal ascendant tract seems almost non-existent, which led us to believe that the tumor was actually originated inside the frontal ascendant tract and was growing outside while pushing the corticospinal tract back. So it was invading the frontal ascendant tract, but it had some relation with the corticospinal tract too. So before we got in the operation, we predicted that this patient would probably have some difficulties in language processing, and we actually braced ourselves. So we have prepared an awake surgery for the patient, an awake craniotomy for the patient. And the patient operated with awake craniotomy, and intraoperative cortical mapping was performed. In the first operation, while the tumor dissection was underway, patient had a speech arrest, which made us stop. We couldn't go further because we were afraid that he was going to lose his ability to speak fully. So we had to speak. We couldn't resect all of the tumor. And after the operation, despite everything we have done, he actually lost his ability to talk. We weren't able to excise the tumor fully, and we didn't have the functional outcome that we expected. It was actually a big failure, not a failure, but we felt like a failure back then. But we had this integrated metaplasticity approach, and the patient underwent underwent an intensive rehabilitation regime where he was socializing, listening to different modalities of auditory input, including music, real-time speech and recorded speech. He started uttering some words in post-operative 5th day and started to form long sentences after first month. So this was critical for us. The first month, he started to be able to speak, and the patient is a young patient. He's 28 years old. He has years to live. He's just married for 1 year. He has a kid. So we made another decision. So we have seen the plastic potential in that area, and we immediately after the first resection, like 1 month after the first resection, we went for another resection, and we then fully resected the tumor back then, and the patient did not lose anything functionally. So that shows us in 1 month, somehow the function has already moved to somewhere else. This is the post-operative image of the same frontal ascent tract. You can see that it was only like 30 fibers mapped in the preoperative one. And here you can see that it looks more healthy now, although there are some places that it's missing. So after 6 months, at his 6-month follow-up, the patient was able to talk fully, and he had no problems with his speech. And okay, I also want to show you the corticospinal tract, what happened to it after the surgery. You can notice that it has moved back to its normal position. If anyone is interested in where its position is, will know that you see it was here, now it came here. Okay, so I will now move on to our second case, which is also very interesting. So this was a 14-year-old female with double vision, vomiting and fall while playing volleyball in 2017. She was a science high school student, which is relevant for our case because what we are going to talk about is loss of ability to make calculations, even the simpler ones. She was diagnosed with AVM in left medial parieto-occipital region back then, and she also developed seizures. The AVM has bled, and it led to developing seizures. She underwent radiotherapy as she was young. And we didn't, their doctors didn't consider the surgery first. So she underwent CyberKnife, stereotactic radiosurgery. And there is a time frame of 3 years that you have to wait after radiosurgery. But after 3 years, the AVM was still there, was still filling with blood. So it was still posing threat to the patient's threat of bleeding, and also she had seizures continued. And then the patient was treated with embolization in June 2021. Post-embolization, she started to have out-of-body experiences. And when we look at what happened to her MRI, we don't have DTI at this time. She only came to our center later. There was ischemia in anterodorsal precuneus, and AVM was still persistent, and her symptoms did not improve. So as you can see, that's her AVM, and the diffusion imaging shows the infarct areas. So then we decided to take on the surgical approach, and we were able to completely resect the lesion. And there were some ischemic areas in postoperative DVI, diffusion weighted imaging, lateral to the resection cavity. Last time she had out-of-body experiences. She had this problem. She started that problem of understanding her body and its relative position in this space. So she was losing the understanding, and it was only the start. So we had ischemic areas in anterodorsal precuneus. As I have shown you before, precuneus is the most connected part of the brain. So it has an important role in this meta-networking of the brain functions. In her postoperative exam, she had left-right disorientation. She couldn't tell her right from her left, or she couldn't say if someone is to her right or to her left. And she wasn't able to do even very simple arithmetics other than addition. Like she was able to add 2 to 3, but not able to multiply, divide, or even do some complex addition like 11 and 12. She was unable to name her fingers. She couldn't tell which finger was which. So, and she also had difficulty writing. What she lacked was actually putting things in space, following in an order that follow each other. She couldn't order things in her mind, the things that she has shown in the real world in space. So this is her post-operative MRI that shows that we have resected everything, but we have infraction in precuneus. And also here, we have also performed DTI with Brainens MD on this patient too. Thanks, Zoe did that, thanks to her. And you can, okay, you can see here that this is the SLF that we were talking about, superior longitudinal fascicle. Due to the acute ischemic changes, we have lost some of the posterior parts of the SLF, and this has been associated with visuospatial awareness. This was the probably reason that the patient lost their ability to understand the visuospatial relationship. After that, we have this patient has also gone an intensive therapy rehabilitation regime. For her, we have devised exercises for her that she had to make mathematical calculations, real world scenarios. She was going to we were simulating shopping, we were simulating going to different places. She was trying to mentalize different objects in her mind and count them. And we actually had very important advancements in a very short time. Like in the 5th day, she was able to calculate again. And after almost 1 month, she recovered all of her visuospatial abilities. And after 6 months, her grades were back to her postoperative level. So I want to say some concluding remarks on the topic. We have to understand that brain is not static. It has an ever-changing nature. We have to understand that every individual has their own history of plasticity and their own characteristic brain structure. And surgery and postoperative follow-up should be tailored to personal needs. And rehabilitation approaches should include real-world problem exposure as much as possible to improve integrative metaplasticity. I want to give my special thanks to my colleague, Dr. Mohammed Yakup Altu, and Zori Giavri and Haris Kataki for their contributions in this presentation. Thank you very much.
Thank you. Thank you for the presentation, Dr. Bahadir. It was very interesting. So before proceeding to the questions part, I would like to take the opportunity and introduce you to a platform that we have recently launched, and it's called Advantis Academy, where you can find all the webinars that have been conducted from our company during the past 2.5 years, including the present one. So apart from the webinars that are hosted in the platform, you can also have access to how-to videos that we have prepared that capture sequence-related processing tips. For example, in case of DTI, you can find videos on a suggested protocol for the reconstruction of specific tracts. In the fMRI scenario, you can gain access to hints about task-based or resting state functional MRI analysis. And last but not least, in case of perfusion, you can learn more about the quantitative and qualitative evaluation through the study of multiple cases that are presented and hosted in the platform. During the following minutes, in the chat section, you will see the link that you can use to access Advantis Academy and sign in. So now we are going to move to the last part of our webinar, which is the questions section. So we are going to start with the first question for you, Dr. Bahadir. So the first question is related to functional MRI. So if a functional MRI was part of the protocol, of the study protocol that was applied for either the first or the second case, would it have been of any further help?
Well, I'm assuming that it probably would, because as I told that the damage was to the precuneus area, which is a very important area in also the resting state fMRI. So we would be able to see how close the lesion was to that part. And although we had taken all measures, all precautions, we might have had a better picture when we got into surgery. But the surgery was rather emergent, so we didn't have time to really perform DTI or fMRI preoperatively.
Mm-hmm. Another question is related to your protocol when you do the speech mapping. This is exactly the question as I read it. And the attendee is asking, how did you do the mapping in an 8-year-old child? I think it was a 14-year-old. This is the correct.
Yeah.
Yeah.
Yeah, she's a 14-year-old. You mean the cortical mapping?
I think the speech paradigm is what the thing that the attendee is referring to.
Okay.
The speech paradigm that was applied, but yeah, I think probably clarification can be written by the attendee. No functional MRI was presented for the cases, but we can probably discuss about a suggested speech paradigm that you can think of that would work for the activation of Broca's and Wernicke's in functional MRI.
Oh, okay.
Like word generation or something like this. What did you use?
We didn't have a similar case after that, but you know, now that we are more informed about the case, our hypothesis at least would be we would ask the patient, we would want patient to mentalize certain images in certain rooms or in certain orders and change their orders. Like imagine 5 different objects and change their orders in your mind. This would probably be a good way to test that ability to do that task. But other than that, what we have seen is was that, you know, the general mathematical ability was really tied to this conception of space and ordering things in the space. We don't really have a clear picture of how that happened, but together with the ability to understand the spatial dimension went together with her ability to calculate. And this is the case in Gerstmann's syndrome. There are some other case studies and about the syndrome too.
Thank you once again, and make sure that you stay tuned for the future events as well. Thank you. Thank you, Dr. Bahadir, as well.
Thank you very much. Have a great day.